Hey, John.
Hi, Zara. How was your week?
Starting in today, if you guys don't know, it's tax day for us Canadians. I'm not a very happy camp, but I'm excited that we have Dr. Edward Kim with us in the recording studio. So, John, I think you're going to introduce himself.
Dr. Edward Kim is from Mount Sinai Hospital. Let the audience know a little bit about yourself and what interventional radiology plays in liver cancer therapy.
Hey, John and Zara, thank you so much for inviting me onto the podcast. Sorry to hear it's tax day in Canada, but death and taxes, right? Two things
Yes,
you can't
death and
avoid.
taxes.
Well, hopefully with death, we can help some of our patients with liver cancer avoid that. Interventional radiology is minimally invasive procedures that are guided by a variety of imaging guidance, whether it's CT, fluoroscopy, what we call continuous x rays, even MRI guided interventions and PET CT guided interventions, as well as ultrasound, all come into play. And we provide a variety of interventions, some for curative intent, some to get individuals to transplantation, as well as what we call palliative, or to extend life, but hopefully to also preserve their patient's quality of life.
So, Ed, you mentioned curative intent. So maybe you could expand a little bit more about that.
Sure, if we're talking about primary liver cancer, or the technical term is hepatocellular carcinoma, we really divide that into various stages. And those stages are very early, intermediate, and advanced stage, as well as terminal. When it comes to curative therapies come into play in the very early, as well as the early stage of HCC, or hepatocellular carcinoma, or primary liver cancer. And for interventional radiology, curative intent therapies would encompass what we call thermal ablation, and a growing data to support what's termed radiation segmentectomy with yttrium 90.
Ed, thank you for that introduction, but I'm just going to segue back because I don't think the audience know who you are. So, do you mind just quickly introducing yourself to the
Oh,
audience?
yeah. Yeah. So my name is Edward Kim. Ed, a lot of people call me Ed. I'm the director of interventional oncology at the Mount Sinai Health Systems, which is a tertiary care facility in New York City with a very large transplant program. We see one of the highest volumes of hepatocellular carcinoma in the country, and we are the only NCCN designated primary liver cancer center in the United States. I'm a full professor of radiology as well as surgery, and I've been treating primary liver cancer for about 18 years.
And I think part of the area of your specialty is within radioembolization because interventional radiology is such a massive, broad topic. So I think it'd be really great if we could narrow it down specifically around radioembolization and its implication within HCC. So maybe you would just want to walk us through some of the top kind of areas and data sets within radioembolization, like Y90 within the intermediate stage and its implication in HCC, and some of the pain points as well.
I would say that radioembolization was recently incorporated into guidelines, specifically the Barcelona guideline, or BCLC, as well as the NCCN, or National Cancer Guidelines, several years ago. And that was based on data from a multi-center or multiple hospitals reviewing their data, submitting it in conjunction with the FDA, and radioembolization with glass microspheres really encompassed that data set and showed an advantage in individuals with solitary or single lesion cancers in the liver up to 8 centimeters in size. And so that helped get adoption of radioembolization into the early stage, but we use it across all the stages, the very early, the intermediate, as you had mentioned, we can go into that further, as well as the advanced stage HCC.
So, as a interventional radiologist, how do you, if you could explain, make that decision as to utilization of it in the earlier stage? So that's more of the neoadjuvant stage versus the intermediate stage. Are there certain criteria that you need to adhere to? And again, I'm assuming following the BCLC guidelines. Is that the main criteria?
Yeah, I would say that the critical component to all of this and utilization of local regional therapies, such as radioembolization, is in the setting of a multidisciplinary working group. And what that means is that there are physicians like myself, interventional radiologists, as well as other, probably more familiar physicians within a group setting taking care of one patient. And those other physicians encompass surgeons, whether it's transplant surgeons, surgical oncologists, medical oncologists, as well as hepatologists, which are dedicated liver doctors. And we
Mhm.
really determine what is probably best for that patient and make recommendations. And then we'll present that to the patient as well. So it's what we call shared decision making with our patients. And that is what's presented for early stage. And the early stage, the intent of all the therapies really should be curative. Patients should be having excellent 5 year survivals. And then when it comes to intermediate stage, that is when historically it's been palliative therapy, but now with advances in the therapies that we provide, as well as systemic therapy or medicines that are given to patients, there is the possibility of downstaging these patients or taking them from a palliative setting and then now potentially giving them a cure with liver transplant.
If I had to go back to one of your earlier comments with regards to having the multidisciplinary team approach, which is fantastic, and you actually involve the patient. So can you just further elaborate on what you mean by that?
Yeah, absolutely. So, for instance, in our hospital, every Wednesday, I have office hours or clinic where I see patients in the office setting. And in that same office setting it's a large space with about 30 examining rooms. I'm
Yep.
sitting in a basically a communal room with our transplant surgeons, transplant coordinators, hepatologists, and then across the street from us are our medical oncologists. And for example, how it would go is a patient is maybe referred to one of our surgeons who will see the patient and say, "Hey, listen, I don't think surgery is appropriate here in terms of a resection, but this patient may be eligible for a transplant." And they'll go over that with the hepatologist as well as the transplant coordinators and get that rolling as well. And they'll say, well, this patient will need radioembolization to get them to transplantation because the tumors have to be within a certain criteria, what we would call the Milan criteria, less than 5 centimeters, or three lesions in the liver less than 3 centimeters to make them eligible for transplantation. But obviously, those tumors aren't going to wait. There's a certain waiting period. And so we provide therapies like radioembolization to destroy tumor in conjunction with our transplant team and our surgeons and our hepatologists so that we can get that patient across that hurdle to get a transplantation.
And do you put
Right.
systemic therapy in with that interventional radiology? Systemic therapy moving into the adjuvant, neoadjuvant setting, or is that mainly left for the later setting?
So I would say that that is a very controversial question right now. I think we're in the beginning stages. Certainly, there isn't what we would call level one evidence or sufficient evidence to support the use of systemic therapies as a bridge or downstaging therapy to get patients to transplantation with or without local regional therapies, usually with. Now, I will say there are certainly trials underway investigating that.
Mhm.
And there is data that is extrapolated from existing data to suggest that that could be something that is feasible. But I would say for sure it's not in widespread practice, and there certainly isn't a high level of evidence to support systemic therapies use in that.
And I think one of the components that John and I frequently discuss is, how to better inform the patient and how to better kind of empower them with some of this information and data. So from your standpoint as a interventional radiologist, as a clinician, when you have that patient sitting in front of you, how do you break down all of the bits of information that you've shared with us so that they too can feel kind of empowered and part of that decision making process to ensure that it's the right decision that's being made?
I can't stress enough the importance of working in a multidisciplinary team. I think we all learn from each other. I certainly learn the data about systemic therapies and surgery from my colleagues so that I can be a better physician and inform our patients about various therapies that are available to them. And by no means am I an expert in the surgical literature or the medical oncology literature. But the fact that I'm aware that there potentially is that option and that I can discuss with my colleagues a patient and get their eyes on it, I think ultimately leads to the best decision for the patient. And then in that process of, I'm an expert obviously on interventional radiology studies. I can inform the patient on those studies. And then I can refer the patient, if they would like, to go see the medical oncologist and discuss potential systemic therapies with the medical oncologist who is the expert. I think that ultimately leads to the best shared decision making. And so I would say that patients going to a center of excellence that offers that probably leads to better care. And there are actually studies that demonstrate that this does lead to better care for the patient. Practices where you're just going to see an interventional radiologist, you may only get offered local regional therapies because that's all they know. It's not that they're trying to hide other types of therapies, it's that they may not be aware that there are other therapies in play. And so I think trying to see that multidisciplinary team for your care, whether it's liver cancer or something else, is extremely important.
As you just stated, the MDT is the better way to go. Many of our listeners may not have that approach as you decided, you just discussed. That referral to a major teaching hospital, how does that discussion go with the patient to the doctor for that referral? How would you educate the patients that are listening to this or even their caregivers on how to get that discussion rolling? Because a lot of people don't know.
I would say that it doesn't necessarily have to be in the mold of how Mount Sinai does it, where I'm physically in the same place as other physicians. I would say that, for instance, there are a lot of different models for this. One model that I'm aware of is that hospitals, and especially rural areas, what's nice, if I can put a positive spin on COVID, is that it's sped up how we do tumor boards and communicate with each other virtually. And so there are virtual tumor boards that go on where multidisciplinary discussions are had, but in a virtual format or a Zoom format, as most people are familiar with. And cases are presented in that way. And that's a very good way of doing it. I know a hospital that is 100 miles away from a transplant center that provides interventional radiology care, but the transplant workup is done at that hospital 100 miles away. So it's much more convenient for that patient to get their interventional radiology treatment close to their home, but then go every 3 months to the transplant center for their transplant workup. And that works as well. And that can work in a medical oncology model as well. Another model that can also work is physicians calling each other up and saying, hey, I have, so and so as a patient. Is there anything you can offer? I'm planning on doing this, but if there is something that you can offer, or if you think this is a, let's say, surgical candidate or a transplant candidate, maybe we'll go that way and make discussions that way and have it at a grassroots level. So there are a lot of ways to go about it. My advice for a patient is to ask. You're in charge of your care. Of course, you're not the expert when it comes to these various therapies in terms of deciding, should I get chemoembolization? Should I get radioembolization? But just to say, hey, doctor, is there a possibility that there are other options for me that other providers that you work with can provide to me? Maybe it's not just surgery. Maybe it's not just radioembolization. Maybe there's a systemic option. And it may kind of have your provider say, oh, yeah, I should call up Dr. So and so, who's a surgeon or who's a medical oncologist or who's an interventional radiologist to get their eyes on this case. And it may very well be that, yeah, sorry, there's nothing I can offer, et cetera, and you're going the right course. But sometimes there could be another option in play, such as synergistic therapies. You're on systemic, maybe adding a local regional therapy there could provide safe and effective care for the patient.
I think you touched upon one comment right now, which is around safety. So when it comes to radioembolization, did you just want to maybe share with us some of the safety aspects of combination of radioembolization with other therapies or just as a single form of a treatment?
Yeah, I will say that there are numerous studies out now, as well as our own prospective studies showing that radioembolization is extremely safe and effective. For instance, in our RAZOR study, which was published in Lancet GI and Hepatology, showed that it was mostly grade 1, 2, what we call adverse events, where really side effects, patients, all they really felt was fatigue, maybe some nausea after the procedure, and then went back to their baseline after a few weeks, even a few days. And so that's been published, meaning it's been reported in a peer reviewed journal, meaning other doctors have reviewed that and said, yeah, this is legit. And then there have been multiple publications now from all over the world, from the US, from Singapore, from Korea, that demonstrates the combination of checkpoint inhibitors, as well as checkpoint inhibitors are immune mediated therapies, and radioembolization are quite safe, that there was not an increase in toxicities compared to other things. And then we published also a combination of radiation based therapies, radioembolization, and external beam radiation, also showing that it's quite safe. And I don't think I completely elaborated on what radioembolization is. It is tiny spheres that are embedded with radiation called yttrium 90 into a glass matrix, and that glass matrix is less than the size of a powdered sugar granule that we inject through the artery after we place a catheter into the destination artery, which is basically a small tube conceptually that courses through the body that we find through x-rays, navigated to just the area where the tumor is, and then we release those small spheres into that area. Radiation inside destroys the tumor, and the radiation is really held just within that targeted area. It doesn't go outside of that because yttrium 90 has a radius of about 3 millimeters, which is extremely small radius. And so everything's contained within where we inject our therapy.
When the patient progresses in the liver, what's the role in the treatment paradigm for metastatic disease?
Well, if we've performed local regional therapy alone or surgery alone to treat the individual to start, and there is, as you say, extra hepatic disease, whether it's whatever set time afterward, it can be weeks, months,
Yeah.
years down the line, then we'll bring it back to our multidisciplinary team and make a decision in terms of what to do. Now, if it's only extrahepatic disease, meaning outside the liver, and the liver is fairly stable, then I think the answer is quite easy. It's to place them on some form of systemic therapy where they get an IV infusion. If they're treatment naive, meaning they haven't had any systemic therapy prior, then they're usually, based on data now, going to get a combination of a checkpoint inhibitor plus something else. If they have been on that in the past, then you know, I'll leave it out, obviously leave it up to our medical oncologist to decide. It may be the addition of what we call a tyrosine kinase inhibitor, which prevents blood vessels from recruiting to the tumor, or they may add something else. But the good news is for primary liver cancer, there are so many therapies now with positive trials, whereas over 10 years ago, there was only one. So a lot of options for patients now. So a lot of hope is what I would say.
I think the other question I had was based on, as you just said, there are so many options now available. And again, depending on what country you are in, you have availability to those. So you and John are in the United States, I'm in Canada. And even within Canada, and I don't know how it is in the US, I mean, depending on what province you're in, you have access to radioembolization and chemoembolization. I guess with that, what are some of the challenges that you kind of anticipate kind of seeing with all of these various options that you now have available?
Some of the challenges are good in the sense that, wow, we have so many tools available to us now. Which one do we pick?
Mhm.
That can be advantageous to the patient. I think what we think about now is quality of life. How will it impact the patient's life? Will they tolerate it? What is their lifestyle? Can they come in every couple of weeks for an infusion? Do they want to come in? Or do they want a single therapy and wait and watch approach and get additional therapy or move on to something else if they progress? So we do have a lot of options. And that is a good kind of, I guess, problem to have.
Yeah.
I think another hurdle, as you were, I think, kind of alluding to, is that especially in social healthcare systems, the cost of these therapies is going to come into play. And so in certain countries, you may not have a choice. As if you're part of this, we're taking private payers out of the picture, you may have something already chosen for you by your socialized healthcare system. And other options may not be in play. And that becomes a hurdle because there are certain cases that physicians will strongly feel that one form of therapy may have a benefit over another, but you may not have access to it. You may not have the means to travel to the United States to get that type of therapy. So I think that is a problem. The other is the education of physicians. I think we this is a fairly new space still in terms of what systemic therapy to use. Is it okay to use it with a local regional therapy in combination? Is it safe? Does it provide any efficacy? So I think the adoption of that really hinges on data being formulated, and that data sometimes takes years to develop. And so there are certain centers that are ready to adopt and push the boundaries a bit. And then there are others that are conservative and say, hey, there's no data for this. We're not going to do this. So that becomes, I think, the gray zone of medicine, where it's more the art than the science that comes into play. And then it's just philosophical,
Yeah.
as long as it's safe.
Okay. Thank you.
When we were originally doing a lot of trials in combination with interventional radiology to show benefit, one of the issues that we had is that interventional radiology can change from one country to another. Now it's becoming more standard globally than it was a couple of years ago.
You're
Uh,
smiling.
I wish I could tell you yes.
It was a hard question, but I had to ask it.
Yeah, there's still a lot of variance in play in terms of the techniques that are utilized by interventional radiologists, not to mention access to certain technologies. For instance, radioembolization is the most mature, I would say, within the United States because we don't have barriers to its adoption and we have CMS or government backing to support its use. There are a handful of other countries around the globe that also, similarly, Canada just got approved, and I understand that it's province to province in terms of
Yeah.
utilization. NHS in England has approval, as
Right.
well as various countries in Europe, Korea. China, in a very limited fashion, just got approval last year. But then places, small countries like Singapore, Taiwan, have it available for them to use. Japan does not,
Mm.
and mainland China does not. And South America, it depends. So you don't have access to certain things. It doesn't create a homogeneous type landscape for these trials. Now, most of the trials from a global perspective, in combination, as you had mentioned earlier, is with chemoembolization. Instead of injecting radioactive substance, we inject drug. That is widely adopted across all countries, but sometimes the technique of how that's delivered depends on the expertise of that institution, that even individual physician. And so that is a factor that's in play. But I will say that with a recent study that has been published, I'm sorry, not published, but presented at various meetings in combination with systemic therapy, has shown that regardless of technology, technique that was used, as well as patient selection, that there seemed to be a benefit in the combination of systemic therapy and chemoembolization.
Are you referring to the Emerald One study?
I am. I'm referring to the Emerald One, yet to be peer reviewed, but I'm sure it will be, but has been presented at multiple meetings. Yeah.
I want to just have a quick chat to you about surveillance. In Japan, Asia Pacific area, they're very aggressive about their surveillance. Do you think that's something that we could be doing more globally about liver cancer because they're looking for cure? We want to get earlier diagnosis. Do you think that it's possible?
Yeah, I think in generally speaking with cancer, early detection of cancer leads to better outcomes. For instance, my mother was recently diagnosed with stomach cancer,
I'm
which has a
sorry.
devastating prognosis, but her physician actually is Korean American and was going by the Korean standards in terms of surveillance of individuals. And he found it at a very, very early stage and my mother had a curative resection. Knock on wood, so far so good. All tumors in general, when you detect them early, the outcomes are very good because the aim from that early detection is curative. And as you had mentioned, Japan has a very excellent national surveillance system for HCC because the Hep C is the predominant underlying etiology in Japan. They know this, and so all individuals have to undergo that surveillance, and they detect them quite early and provide curative treatments, whether resection or ablation for those patients. When it gets more advanced, that's when it becomes harder to maintain and control that tumor because it's the cat's out of the box. And so that's where systemic therapies come in play. I think surgeries and local regional therapies, which is what interventional radiologists provide, is really a whack-a-mole type of situation. As tumors arise, we kill it. But it's not taking care of the underlying cause of that, which is a cirrhotic liver or some other etiology. Now, in the United States, I think we've certainly made efforts at the regional level to screen individuals and put them on surveillance protocols who have hepatitis B, who have hepatitis C, alcoholic cirrhosis. But what's becoming more prevalent now, which is very hard to have patients undergo surveillance, is what we call MASH, individuals who have fatty livers. I think that is becoming quite difficult because the United States in general has an obese population, and that can certainly be a contributing factor for MASH. I don't think it's cost effective or effective to potentially place these patients under surveillance protocols. But again, now I'm starting to talk outside my area of expertise. And certainly individuals, and I'll name Amit Singhal as one because he is doing research in this type of area. In his research is certainly needed because we need to catch these early to have the best outcomes.
Maybe we could get Mount Singhal on Med Insights Unleashed to discuss his proactive approach.
Absolutely.
I think that's a great idea and suggestion. Thank you. Thanks, Ed.
Yeah.
MASH, do you want to help define it for the audience? Because it used to be
Um,
called, right? Non-alcoholic steatohepatitis.
it used to be called that, and I think we wanted to. I don't know. I guess we wanted to be more PC, and so metabolic steatohepatitis I think is more, I guess, appropriate. But fatty infiltration of the liver can certainly cause some damage. And the underlying cause of one of the underlying causes of cancer arising from a damaged liver is what is prevalent in just cancer in general, is that an organ such as the liver is trying to repair itself over and over and over again. And in that process, unfortunately, a mistake can happen. And when that mistake happens, it can potentially lead to an overgrowth of cell, which is what cancer is.
Mm.
I have one other question to ask, and that is around your any interesting studies like within radioembolization that you're currently working on or within Mount Sinai that you're able to share?
At Sinai, we're working on, in conjunction with Dr. Purisa Tabrizian, a downstaging protocol. She's one of our transplant surgeons here, so that we can use radioembolization to downstage individuals or take them from a situation where they're not eligible for transplant because their tumor is too big or too many. And then we use radioembolization to make them within criteria for transplantation. And then adding a systemic therapy onto that patient's care and bridging them the rest of the way with the systemic therapy to transplantation. So that is one of the things that we are investigating. And if that is positive, that could be, it's an overused term, but a game changing type of therapy, because individuals who potentially never had a shot at transplant could get a curative treatment for themselves. And I think two other promising trials that are underway is what we call Rowan study, where it's, again, a combination of radioembolization and systemic therapies with checkpoint inhibitors. And then another similar type of study, but encompassing advanced stage patients, is the Emerald Y90 study. And that is also a combination of radioembolization and systemic therapy with durvalumab.
The Rowan study is in the earlier stage setting?
It is earlier intermediate stage, from my understanding. We're not a center that's enrolling for that. And then Emerald Y90 is more the intermediate / advanced stage.
Lots of interesting trials in future for the patients to get more up to date and possibly a cure for the treatments to come, right? So a lot of hope there, what you just said, Ed.
Absolutely.
And I think, John and I always like to, again, part of the Med Insights Unleashed is, our focus is really for those patients and the caregivers. So any parting advice that you would like to share with us in turn for those patients and those caregivers that are out there?
I would just tell them that, whatever stage diagnosis you receive, just understand that there are so many options now to treat primary liver cancer, and including radioembolization, which had just been incorporated into guidelines in 2022. So just 2 years ago. The technology has been around for close to 20 years, but it took a lot of effort and studies to incorporate radioembolization into the guidelines. And that also goes for systemic therapies. We had, again, just a single therapy from a systemic standpoint for well over a decade. And in the last few years, 4 to 5 years, there's been an explosion of data. And so I would say, never lose your hope that there will always be researchers and physicians that are conducting trials, and you never know when there's going to be a breakthrough. And so we are, as physicians, offering the best that we have currently, but there's also stuff in the pipeline that can even make things better. There are situations where it seems hopeless. You're told there's nothing to offer. There's, just to go home. And those individuals sometimes go to places like our center and we say, no, that's not true. And we offer therapies and the patients are now 6 years out. I have countless patients like that. But we are offering, as physicians, cutting edge stuff. So always, always be inquisitive about that.
We couldn't finish the podcast on a better note than that, Ed. So thank you very, very much for all your education and your insights today. And we look forward to interviewing you even more in the future about these coming up trials.
Thanks, Ed. Thank
My
you very much.
pleasure. Thanks
All
for
right.
having me on the podcast.
You're welcome.
Bye-bye.
Bye.
Med Insights Unleashed disclaimers. This podcast is for general information purposes only and should not be considered healthcare advice in any way. The podcast is not intended to replace professional medical advice. The use of the information and material linked to the podcast is at the user's own risk. MedInsights Unleashed is not responsible for any losses, damages, or liabilities that may arise from the use of the podcast. Importantly, please consult your healthcare provider for individualized guidance and treatment. Thank you, and we look forward to you being with us on the next MedInsights Unleashed podcast.